Thank you, Edna, very much for those very warm words, and good afternoon, everyone. This is my second visit to this hospital and to talk about this Genomic Medicine Centre in a week, and I always love coming to Liverpool and to the northwest, and not least because at the moment you're the top of the cake leaderboard following the rather delicious cakes we had at our visit just over a week ago. But I'm really pleased to be here at this launch event because also this Genomic Medicine Centre is at the top of the leaderboard in terms of delivery against the agreed trajectory with NHS England. So there's a lot to congratulate yourself about today. But equally, as Edna's already said, there's a lot still to do to ensure that at the end of the project that this part of England is embarking upon, that we ensure that that's embedded for the future and that there's a seamless transition at the end of the project. Now, this whole project started in 2012 and it followed the Human Genetic Strategy Group publishing their document. In December of that year, the Prime Minister then announced that the government intended to achieve, based on all the genomic technologies that was in play then, was about to come into use, a paradigm shift in the way that genomics would be used across the NHS. I put that in because I think it's important for everyone to realise the level of scrutiny that this project has with the changing government, the same Prime Minister being in place, the same Minister within the Department of Health, sitting between the Department of Health and the Office of Life Sciences in George Freeman, have in terms of their expectations of delivery. And hence at the moment why I'm on a weekly report to the Department of Health for delivery for each of our 11 genomic medicine centres. And what he did is he committed the UK and particularly England to sequencing 100,000 whole genomes in rare disease and cancer by the end of 2017. But part of this paradigm shift in the way in which genomics was to be utilised in the NHS was this sustainable transformation for the future by the end of this project. And we're already discussing with the Department of Health what the legacy will be in 2018 and beyond, given the planning cycles that we all work with. And we know at the bottom what this will drive is a better understanding based on our genetics of why disease occurs in individuals with rare disease and cancer, and how that genetic change is actually expressed in individuals in their actual phenotype. So what we've seen in response to this project and to the 200 million that's been put in by either the Department of Health or other funding bodies, as well as the 20 million by NHS England, is this coordinated response across health and care. And I have to say everyone is working together, particularly given that level of political scrutiny to delivery. So the Department of Health is ensuring we coordinate the knowledge to make the UK a world leader. Genomics England, the limited company that's been established to procure the sequencing provider and the ability to annotate that sequence by another external provider, owned as a single shareholder by Secretary of State itself, is actually sequencing or arranging the sequencing and the matching of that sequence with the clinical phenotypic data through Genomics England. NHS England is turning our knowledge into interventions. Health Education England is working on making sure that we've got a responsive workforce. And Public Health England separately in a genomics programme is looking at using the genomic knowledge of looking at certain microbial pathogens for protection and health protection, and looking at that in the context of other initiatives across the world. There are four main aims to this project. The first one is increasing discovery and understanding of new genetic variants that may cause disease, but also that may lead to newer treatments, devices and diagnostics. And a point I often make here is it's not all about new treatments though. Some of it will be how we use existing treatments better. And that's what the first sequence has shown that was returned in Newcastle to a patient with an inherited neurological condition, that it was about using an existing relatively low-cost treatment in that particular condition. The second aim is to accelerate the update of advanced genomic practice into the NHS. And this isn't about holding up all the knowledge in specialised genetic medicine, doctors. And I think this has been exemplified in this Genomic Medicine Centre with the work that Lynn Green has done with others to ensure that this really is embedded across clinical specialties, so it will be integrated into the NHS in the future. The third is how we increase public understanding and support for genomic medicine and using genomics, and what that might mean for families, for actually individuals. And finally, it's to stimulate and advance the UK life sciences industry. So the UK is a place to come and do research and development for the future. So in NHS England, we went through a period of time thinking about the best way to really harness the NHS contribution to this. And we went through various iterations of whether this should be just some 4 big centres around the UK where there may not be equity of access to all participants or all of the population who were eligible. But we decided against that and went for a distributed model. So we're committed to delivering 90,000 of those 100,000 genomes by the end of 2017. In reality, this means by the middle of 2017, not to scare anyone, because the rest of the 6 months is taken with finishing, doing the sequencing, doing all the annotation and sending it back to the genomic medicine centres for validation. But we went through a really robust 2-stage process to designate 11 geographically dispersed NHS genomic medicine centres with a lead organisation, so a prime contractor model, working with local delivery partners and partnership agreements. And this was against quite a challenging service specification, from consent and recruitment of patients through to clinical feedback and service transformation, and also really robust governance and partnership arrangements, which I think the North West Coast exemplifies in terms of what you've done. And I can say that having gone round to all 11. The robust contract sets out expectations and activities. Within that, there's only payment and financial penalties for unsuccessfully sequenced samples, and a range of both quantitative and qualitative KPIs so that each genomic medicine centre is benchmarked against the best in class. We had a lot of robust discussions about that. Was that really fair? But it is a benchmarked approach in terms of ensuring that there's continual improvement and working always towards the top quartile. We have in place an NHS England implementation unit to directly support genomic medicine centres, and later this week we'll announce the second wave of genomic medicine centre procurement. So we're looking for a possible 2 to 3 other genomic medicine centres to complete the coverage across England. There are some notable gaps, as you'll see on this next slide. So there you are, the northwest coast, extending right the way through from Cheshire up to the very north of Preston there. And so the key element of genomic medicine centres in terms of their anatomy and physiology was that they had to work in partnership with academia, with patients and with industry, and through the academic health science networks. And I mean, there's been tremendous support in this geography from the academic health science network. and we should thank them for their support. And I've already said that the lead organisation here, Liverpool Women's Hospital, I mean, absolutely superbly led by Angela Douglas. I have to say she's been a real driving force for ensuring that the North West Coast was definitely on the map, stayed on the map, and everybody did what they needed to do. So we should congratulate Angela for that. These are the key functions of the Genomic Medicine Centre. So there has to be recruitment and consenting of patients across specialties, and both Lynn and also Carlo, with the cancer leadership role here, are really working with their clinical colleagues to ensure that that happens, and that everyone across this footprint really knows what's required. The second is to have active patient and public involvement. I mean, Keith has been an absolute champion, and we use him and roll him out as much as we can. And this is about patient and public participation and active participation. And there hasn't always been the opportunity to make the changes you want, but at least your voice is being heard about how we can do that differently. What's been the major challenge, but also the huge opportunity, has been the need to get informatics systems and both the hardware and the software to work across the geography. Easy to say, but in reality quite difficult to achieve. And this has been critical. So in some organisations there's been over 600 different systems that have had to come together for data to be extracted, and then eventually that data, that clinical phenotypic data, to be uploaded into the Genomic England data repository. And I think the informatics leads in this trust and what they've done across the footprint has been amazing. From essentially a relatively low start to where we are now has been fantastic, and something you need to be proud of. The bottom indicates that samples have to be collected, processed, and all the logistics have to be in place to make sure these are done at the quantity and quality required. Thankfully, this GMC passed at the first go through all the external quality assurance schemes that we put in place for both blood and for cancer. And this bears testament to, I think, the quality systems and management that you have across this footprint, but it's also driving how you're thinking about your laboratory services for the future. There needs to be post-annotation, validation and reporting in conjunction with multidisciplinary teams, and I know that you're thinking about how this might be done differently, and integrate into existing, for example, cancer multidisciplinary teams, but new types of approaches to engage all the team. Results have to be returned to participants, and clinical care delivered according to guidelines, so that a patient in Preston or Chester who were participating would be the same as they are here in Liverpool. The transformation to the NHS has to be measured, and the workforce has to be upskilled. And I've already mentioned the importance of partnership and network working across the geography. So I'm just saying, Edna, from my perspective, I know that there's been a tremendous amount achieved against all of these key elements of what makes up a genomic medicine centre. So how does this all fit together? This is a complicated slide, but it just actually rather simplistically illustrates what's going to happen. At the top, there's patients and families who are providing their samples and their clinical data. There's the genomic medicine centres who are capturing the clinical data, processing the samples, providing them in this side to a sample repository, and then on to a sequencing centre, and in the middle to a clinical data store. Other data will be pulled in from other types of records over time, so that we've got a longitudinal record. And then in the middle, there at the bottom, there's a research database that brings together the sequencing outputs and all of the clinical data. And what it means at the bottom is that NHS clinicians can access this, so we've got dynamic clinical interpretation and really state-of-the-art of interpretation for clinical care purposes. But also there can be academic developments in the form of research studies and also research projects. This can be used also for training purposes, and also because this creates a reading, not a lending library, can also be used for industry to sponsor certain studies or to provide enhanced type of investigations to look up the data. But more likely it's going to be new projects and new diagnostic discoveries. So it really does fit together. Now, a key element of what's been created within Genomics England is the Clinical Interpretation Partnership, and many clinicians across this footprint will be contributing to this. And this will aim to drive the adoption from new understandings into clinical practice in a much enhanced pipeline. So from the usual 11 to 17 years, depending on what you're looking at, down to about 3 years. There's also a consortium of a limited number of industry partners already working with the data. But this is the real I think, nub of some of the changes, because this will enable that dynamic clinical interpretation of patients' data, and that data to be refreshed with new information that's sent from this Genomic Medicine Centre into that data centre, so that patients' therapy really remains at the cutting edge of knowledge. So this is what it looks like if you put it all together. Let me just build up that slide. So at the top end, that's what the Genomic Medicine Centres are doing. In the bottom, from the biorepository, the sequence, calling the variants that are seen in the sequence, and the reports that will be made available to the laboratories. That is all done by or contracted by Genomics England. The interpretation is the element that will be enhanced by clinicians and academics across the whole of England, indeed across the whole of the UK, and some international experts, to make sure that interpretation remains at the cutting edge. So this is really one of a transformation in how medicine and how the use of genomics and genomic technologies are brought to bear. But the critical element is the linking of the sequence data with the clinical data. I've already mentioned that Health Education England is working on a range of interventions to support the development of the workforce, because this will be critical. It has to go hand in hand if we're really going to get benefits for patients. And I've also been working on supporting the education and training developments. And I'm really pleased to see the innovative approaches that are being considered in this Genomic Medicine Centre to ensure that that happens. Now, just to finish, whole genome sequencing will give us a whole raft of new insights. At the moment, what it will do is let us look at the whole genome of individuals. We only look, and that isn't necessarily the case in all patients who have any form of genetic testing, at the exome, so it stops at that first dot there. That's about 1% of the whole genome, and that's because that's very important in terms of how it tells us what sort of proteins can be developed. Along the bottom and across this slide, you'll see that, and it doesn't matter about the detail, what whole genome sequencing will do will let us understand genetics and genetic variants in a way that we've never had available to us before, in a more systematic way in the NHS. And what our aim is in the NHS, as part of the personalised medicine strategy that I'm now working on, and indeed our first board will be in London tomorrow, chaired by Sir Bruce Keogh, is we're starting to embed not only the use or think about the use of whole genome sequencing beyond this project, but also how we can embed the whole of this functional genomics pathway. So we understand all the possible genetic variants, but also the way in which we can understand how proteins are produced in the body in response to any of the genetic changes, and also the type of markers that might circulate in a patient's blood that enable us to look in a much more non-invasive and fairly simple way at what's happening in an individual, so how their genetic code is being expressed. And this will give us a real opportunity to monitor treatment differently, but also to look, for example, at how cancer may reoccur. This is a simple way of describing that, because what we know is that all of us have some genetic variants, but they don't always translate into us developing disease. So we have to understand this whole pathway to understand whether it really leads to abnormal organ function. But if we start to introduce this rather complex pathway, what we know is we'll start to categorise disease differently in terms of whether it's associated with inflammation or whether it's associated with a disordered immune response. We can only characterise that total abnormal organ function by other diagnostic tests. When we put all of this together with the type of symptoms that patients present with, what we start to get is a similar disease in terms of presenting symptoms, but very different phenotypes on the basis of what their genome is telling us or how that genetic variant is being expressed. And this is really exciting. It opens up a new era of integrated diagnostic operations. So it requires us to link all of our diagnostic tests together and to ensure that our endoscopy services, all of pathology, all of imaging, all of physiology is at the cutting edge as genomics is, and genomic technologies will be for the future. But our challenge is how we bring all that together, and in an individual patient we create individual diagnostic profiles, because that's what will tell us the treatment that's required for an individual patient. Now, what we've got through integrating this is the possibilities to use more machine learning rather than human resources to look for patterns in data, and that's where we'll also get some of the efficiencies. And what we know is associated with even genomics, we're seeing technological change that's driving some miniaturization and some handheld diagnostics, even in the genetic space and genomic state, as well as centralized big robotic and big molecular platforms that really drive us towards centralization. So there's a real opportunity here for us to introduce personalised medicine and at the same time drive efficiencies, better value for money, and working in partnerships across geographies. And that's what our strategy will be about. It will be about bringing that functional genomics together with phenotypic diagnostics so that we create an individual picture for each individual patient, and then link that with the potential therapeutic options. But that will require searchable databases that are currently not available. So precision, personalised medicine underpinned by precision diagnostics will enable us to better predict disease, to better target prevention and new strategies, to provide a more precise diagnosis, to stratify therapies for population subgroups, so for the same disease but with different phenotypes, instead of treating everyone empirically and as a homogeneous group, to introduce new forms of diagnostics that actually see, for example, a targeted treatment combined with a companion diagnostics. And this is where there's a really exciting area where technology will take us, where we'll see devices that will be able to do both, will be able to diagnose the problem and also monitor the therapeutic at the same time. And we've seen some tremendous changes, for example, in diabetes that are soon to come to market, with a more participatory role in all of this for patients and what they can do at home. And these are the 4 Ps of precision medicine. So it really has opened up a new way of thinking, a new source of information about an individual's health, and a better understanding of their conditions and disease progression. NHS Genomic Medicine Centres are already working differently, and it's driven major changes in how they work together in networks, in partnerships for patient benefit, with the patient right at the centre. And what precision medicine will do will bring a new taxonomy of medicine for the future, and it's here now, and we have to plan for the future to ensure we can deliver personalised medicine for all. So it's moving from one-size-fits-all to individually tailored approaches. And we know just from some recent evidence in neonatal diabetes that if we use genetics along with more detailed individual characterisation of patients, we can see here that there were 5 new genetic subtypes as a result of new genomic technology applications. That, coupled with more clinical information from other diagnostics, led to 5 different therapy options in those babies that previously would have not received that treatment at all and would have had a very poor outcome. So the future of personalised medicine services will be underpinned by a new approach to integrated diagnostics with genomics at its centre. So we'll move to individual diagnoses and phenotypic profiling, not just diagnostics, a responsive and aligned workforce, more quality assurance but dynamic clinical interpretation informed by the evidence base. And this will ensure that treatment is right and appropriate and evidence-based. It will drive organic innovation and advances. It will support and inform patients. And more importantly, and what our challenges in NHS England is how we align the commissioning system, the levers and incentives and the perverse incentives in the system to deliver new services for the future. But what we do know is the future will be about networks to ensure national consistency while delivering locally, and will look quite similar to what we're starting to see through the Genomic Medicine Centre. So here, there's a real opportunity to have a crucial role in leading the integration of medical technologies across the NHS in this part of England, to build an understanding of the changes that are coming with a new taxonomy of disease, and from using genomics integrated with other diagnostics to fully explore the consequences for future health care across this northwest coast, to really drive those ensuring partnerships across this geography, and how that this can drive the service transformation that's going to be necessary, to lead the development of new models of care and new commissioning processes, and to be really at the front foot of what we'll be publishing during this financial year in terms of the strategic approach from NHS England, and really driving the development of knowledge, skills and experience, because without that there will be a halt in the proceedings and we won't get that systematic and transformational change. So thank you very much, Edna. I hope that's been helpful.